tell us a little bit more about steroid delivery. We all kind of think of topical budesonide. Is there a role for steroid-eluting stents at the time of surgery or in your office or in your practice?
So I'm going to say a strong yes for that because it's a way to get basically steroid to target in a very reproducible way and predictable way. You can think about the sort of standard 370 microgram Propel Mini, Propel Contour versus SINUVA, which is a much higher dose. The SINUVA mometazone implant was designed for recurrent polyps after ethmoidectomy for delivery in an office setting. And so I will offer that to patients quite a bit when they're not doing well. And the conversation is basically we can, do this procedure in the office, place this dissolvable device versus putting you on a biologic, which is probably an indefinite commitment. And most patients don't like the idea of an indefinite commitment to an injectable medication. I mean, all the studies seem to show that the patients will respond to your favorite biologic, but when you stop the treatment, the symptoms quickly start to return. It's not what we hoped it was going to be. We hoped that you would treat them for a brief period of time, the system would reset and you'd be done. That's not what it is. They need to be on it continuously. Now, some of that might be because of how the studies are designed, right? It's if you're pharma wanting an indication for your billion-dollar drug, you don't want to show that you only need a finite treatment course. You want it to be open-ended. But all the available data and the kind of the anecdotal clinical data shows that when you stop the biologic, the underlying disease process reverts. And so when you make that choice to patients, many of them will opt for, having a mometazone implant done in the office.
And when they do the implant, they don't have to do budesonide irrigations, that the implant's gonna do the work for them?
While I tell them they should still do the budesonide irrigations, I'm not sure they're as compliant with that as they should be because you can check when they're asking for refills. But what I say is that the implant kind of gets things going. It's not going to be an indefinite presence, right? It's 90 days and probably the first 45 are the most important. So you open things up again and then it allows again the budesonide to get in. It's sort of the same idea behind the original polyp surgery, kind of open things up, reduce the disease burden, and then let the topical steroids take over again.
And just to play devil's advocate a little bit, so to the patient who's saying, "Okay, I'm going to be needing topical steroids indefinitely or doing this shot indefinitely," like, why is one better than the other?
Well, I think the main difference, the thing that's most understandable from a patient perspective is the systemic effects, right? I mean, one of the unique things about what we do is that our body space is accessible to the outside world for diagnosis and follow-up evaluation. It's not like asthma where looking in the lungs requires a bronch, or if you're treating the GI tract, it's a whole different game. And so we have a unique opportunity to sort of assess pretty much everything that's going on. And if we can, in my mind, it's all about drug to target, right? And we have an accessible target in a way that a lot of our other medical specialties don't.